Hi, everyone. I'm an emergency physician based in Brooklyn, New York, at Maimonides Medical Center. It's an honor and a pleasure to speak to you today on a topic of particular relevance to practitioners in a developing system, which is quality improvement. I'm going to spend a few minutes discussing quality improvement more generally and describe how I expanded our QI process by engaging all of our trainees. And then I'll present a few cases uncovered in this expanded process that illustrate some key emergency medicine principles. All departments should have a process for evaluating the quality of care they deliver. This is usually called quality assurance, quality improvement, patient safety, or peer review. In most departments, this process is carried out by a small number of attendings. In many departments, it's just one person. I think it's useful to distinguish between proactive and reactive case reviews. Proactive reviews are when you look at a set of cases that meet pre-specified criteria. So, for example, we are mandated to do proactive reviews by accrediting organizations or payers against performance metrics like sepsis, STEMI, stroke, trauma. Most emergency departments also proactively review departmental mortalities. And all departments have to have a process for doing reactive reviews that arise from concerns from other departments or complaints from patients or cases that are otherwise known to have gone wrong. In my department, this mostly occurs at a weekly CQI meeting, which is an open, constructive forum that all clinicians in the department are encouraged to attend. The output of these processes may include provider and departmental report cards, morbidity and mortality rounds, or referral of cases to hospital level committees such as risk management or root cause analysis. This traditional quality improvement process is, first of all, very limited because it's usually just very few people reviewing cases. It's also a mostly reactive process, meaning that attention is focused on cases that are already flagged as problematic. And this covers the activity in a sort of dark cloud and often results in defensive corrective actions that are agreed upon in hospital committee meetings for the purposes of getting the hospital off your back, even if you know the corrective action will not improve care and may even worsen it. This is called quality theater. And it's largely an administrative exercise, the kind of thing that just needs to get done every month, like paying your electricity bill. And so it's done without a lot of enthusiasm. So years ago now, when I was assistant residency program director at a different institution than the one I'm at now, we took our existing QA program and integrated all 60 residents into a reinvented process as a continuous core component of the residency curriculum. And we called it clinical quality review. Because we increased the manpower, woman power, by more than a factor of 10, the number of cases we reviewed increased dramatically. Because of this greatly expanded capacity, we were able to proactively review sets of cases that we know are high risk. And so we can find instances of suboptimal care, near misses, that we can respond to constructively because we identified them proactively rather than defensively, as we sometimes do when we're answering to a hospital referral. And because the activity is driven by residents who start out as eager interns and then end up seniors nervous to practice independently, the focus is on learning from our mistakes and how to do better rather than on optimizing metrics and pacifying administrators. So how do we do it? We identified a variety of CQR case groups representing high-risk patients or having otherwise high educational value. Each group was assigned a team of residents. Most groups had between 2 and 5 residents. And then each CQR block lasted for 6 months, and then the residents were reshuffled. So that in a 4-year residency, each resident will have participated in 8 CQR groups. The residency encompassed 2 hospitals, so we had 20 total groups, and for each case group, we created an instructions document and a database template. The instructions document described how the objectives of the review for that case group, and then presented detailed directions on how to perform the chart review and populate the case group database. And the database, which is the primary product of a clinical quality review, is a spreadsheet containing all of the patient data pertinent to the case, as well as the reviewer assessment of the case. This is a fictionalized sample of a database document for the mortalities group that's been filled out. You can see that for each patient, which is in this case departmental mortalities patients, there are some demographic details and then a case summary, and then the reviewer's comments around opportunities for improvement. Sometimes these opportunities improvement have to do with provider level issues, but we try to focus on what are called latent errors, which are errors waiting to happen, resulting from unsafe systems. Many bad outcomes that seem to be caused by provider mistakes are, when you dig deeper, actually caused by systems issues, latent errors. Every month, these cases were presented at CQR Conference, an open forum where difficult cases deliberated and learning points and opportunities for improvement were discussed. We published our experience developing and refining this process some years ago, and the program continues today at its original institution, and I've brought it to my current department at Maimonides as well. Didactics are, of course, crucial for training and remain salient throughout your career. But in terms of actually changing and improving your practice, the biggest impact, once you've graduated away from the steepest part of the learning curve, is reviewing cases. After you review enough cases for long enough, you start to see your patient encounters and certainly your documentation through the lens of peer review. This is certainly what has happened to me, and it has improved my effectiveness as an emergency doc far more than the reading and other didactics that I've done. So it's worth your time to develop a robust peer review program and to engage as many people in your department in this program as you can. So let's talk about some clinical lessons from CQR cases. I'm going to present these lessons in a sort of rapid fire format. And for each lesson learned, I'm going to start with the conclusion and then present the supporting case or cases. And the first lesson is exposure. The take-home point is to expose the patient. This is playful dog versus eye. You can see there's a nice little bruise there. And you can see the fluorescein that was used by my resident who evaluated the case before I got to her. You guys might or might not notice that there's something else going on here. There's a decent lid lack. It's pretty subtle. My resident didn't see it. I did. Why? Is it because I'm so experienced and smart and handsome? Yes. But also because I attach a powerful pen light to my shirt at the start of every shift, and I shine it at everything. I don't carry much with me when I'm walking around the department. I may not have a pen. I probably don't have a stethoscope, but I always carry a pen light, and I carry an expensive pen light. This is a great pen light, but the reason to carry an expensive pen light is because you'll never put it down because it's too expensive. You'll just keep it clipped to your scrubs, so it's always available. Having a bright light is one of those things that you don't know you need until you start carrying it. Here's another common way we make mistakes by lack of exposure. This is an email sent to me by my boss at the time. His name is Andy Jagoda. A 75-year-old presented with vomiting and abdominal pain, and we tried to discharge her. The nephews said, no, continue to work her up. And so we did. And we got a CAT scan, which showed an incarcerated inguinal hernia. So my boss, Andy being the true master, says, I am not being critical, since I am certain I would have missed the hernia. This is a genius way to send someone an email saying, you screwed up. But then he asked the question, would a careful exam have picked it up? And the answer, of course, is yes. If you're looking for a systems way to reduce errors, have your technicians disrobe and put in a gown every patient who presents with something other than an isolated extremity complaint. We've all heard this one, and it is so true. When we look back at cases gone wrong, it's tachycardia that was often the clue. However, I am convinced that respiratory rate is the most important vital sign, that tachypnea is the most important indicator of illness. But respiratory rate is never accurately measured. So unfortunately, we cannot rely on this crucial vital sign and incorporate it into our practice. So that just leaves heart rate. Be very mindful of discharging patients with tachycardia. You can do it, but do it cautiously. Do it reluctantly. Don't try to follow the note here. I've pasted a few notes into this presentation to create a sort of reality show feel, but I'll explain. The case is a 24-year-old female who presented for progressive neck pain. Started 2 weeks ago after she was using weights and, quote, pulled a muscle. Seen twice at another department, treated with the usual back pain medications, now comes in with worsening pain, bilateral arm weakness, which is in quotes in the note, and occasional loss of urine, secondary to being, quote, unable to get to the bathroom fast enough. Patient was unhappy with the care she got at the other hospitals. She's demanding imaging studies. Her exam was reportedly normal. It's not hard to put yourself into the shoes of the providers who discharged her on this visit. Fortunately, she actually never left the hospital. She tried to leave after she was discharged, but she couldn't walk. So she was ultimately brought back in a couple hours. And she saw the next treating team on the next shift. And of course, she had an epidural abscess. For no particular reason, no identified risk factors, just your everyday 24-year-old female who presents with neck pain after lifting weights and has an epidural abscess. It's a tough case, even though there were some red flags. I can see myself explaining away those red flags as the providers did, except for this. She was persistently tachycardic, never addressed in the notes. And why would it be? It's a neck pain in a healthy 24-year-old. Who cares about the vitals? You do. Be deliberate about vital signs. I force myself to see the vitals on every patient. I make my resident comment on the vitals in every presentation. I may not see the patient, but I always see the vitals. Here's another miserable case. This note is from the second visit. A young woman came to the emergency department with leg pain after a long plane flight. She had a negative DVT study, was treated as cellulitis with Keflex. She came back 2 days later. Her leg was much worse. She had gas on the x-ray. The diagnosis was necrotizing fasciitis. Here's the operative note. You have to love the editorializing on the part of the surgeons. Unfortunate 39-year-old physician, mother of 3. She lost her leg. Tough case, right? She was just off a plane. Should have been a DVT, except for one thing. Her heart rate was 140 at 6 p.m. And then a few hours later, at 9 p.m., just prior to discharge on the index visit, it was 136. Sometimes patients with tachycardia should be discharged, but do it reluctantly, carefully, with explicit documentation and deliberation. Here's another lesson learned. Review results before discharge. This young, healthy woman presented with vomiting, diarrhea, abdominal pain, distractible lower quadrant tenderness. Here were the labs. Unremarkable. She felt better. She was discharged. She had a nice discharge progress note. Seems pretty bulletproof. She came back very sick with perforated appendicitis. Okay, that can happen, right? That happens. Young, healthy woman, vomiting, diarrhea, distractible tenderness, felt better in the emergency department, discharge. You can't catch all of them, except for this. 26% bands. Note that the total white count is normal. A normal white count and a normal differential shouldn't reassure you when you have other reasons to be concerned, but a very high white count, and especially a predominance of immature whites, should make you pause. I would not have sent this woman home with 26% bands. I suspect most of you are the same. The differential was not resulted when the labs were initially checked, but it was resulted before discharge. It came back after all the other labs. Check the results before discharge. This is a very famous and consequential case of Rory Staunton, healthy 12-year-old who presented with fever, vomiting, leg pain, was sent home, died of sepsis. The parents were friends with a New York Times reporter. This was in the actual New York Times article. His results, 53% bands. Not known to the treating team. Now, if they didn't get a CBC on the index visit, it's probably a defensible discharge. With 53% bands, it's obviously not. Another reason not to order routine tests. But also, check results before discharge. In the United States, this case led to a lot of well-meaning work being done on sepsis that has led to terrible guidelines that are enforced with hospital penalties which have demonstrably worsened patient care, all because results were not checked before discharge. Check results before discharge. The next lesson learned from CQR is to do a higher resource workup when your assessment is limited. What does that mean, higher resource? Folks often use the term aggressive or conservative to describe the intensity or the costliness of a workup, but these terms can be confusing. The undifferentiated abdominal pain patient with a negative workup but ongoing pain, is it conservative to admit that patient, or is it conservative to send that patient home? Activating the STEMI alert on a patient who is clinically borderline for STEMI, is that aggressive or is that conservative? We all understand the concept. It's doing more or doing less. And I think those terms, more and less, are actually good ones. But I usually use the terms high resource and low resource. Those are the most unambiguous terms I could come up with. And framing it in that way also conveys that there's a cost and harm to doing more, which is a very important consideration when you're having these post hoc discussions about cases with bad outcomes. Here's a case I saw a long time ago, 13-year-old nonverbal autistic female with what I called an apparent sore throat, refusing to swallow, grabbing the throat. 2 episodes of emesis, no fevers, exam normal. We did a rapid strep test that was negative. Isn't that great? Rapid strep negative. So reassuring. She was discharged. She returned a few days later, had many sheets of paper in her esophagus that required 3 specialist teams to remove. The message here is to distinguish between patients that can be reliably assessed and those who cannot. The most common reason patients cannot be reliably assessed is because of limited cognition from age, intoxication, or some other brain problem. The exam is obviously limited in patients who have no sensation below a spinal level, or in patients with a bad peripheral neuropathy. And then there are the patients who have normal cognition, but there's a communication gap. Language and culture can still interfere with effective communication, even when you use a professional translator. And then, unfortunately, sometimes you just can't take the time to properly assess a patient. In these circumstances, use a higher resource workup. That means more tests, longer observation, lower threshold to admit. Quick side pearl here, give your patients your phone number. One of my residents wrote this note to me. He saw a young woman with a laceration. He repaired it, but he was concerned. So based on my recommendation, he gave the patient his card that had his number on it. A few days later, she sent him a picture of her hand. You can see it doesn't look right. He brought her back and he dealt with it. You can learn so much and save yourself so much grief by breaking the rule of emergency medicine that stipulates that when we walk out of the department, nobody can touch us until we return. I do this with a Google Voice number. which may not be available in Libya, but you may have similar services, or at least you can give them your email. I give out this number to tons of patients, and I maybe get a call or two per month, and I'm always glad they called. Almost always. RTFE, repeat the friggin' ECG. Sometimes it's really hard to decide if you should activate a STEMI alert. Time is myocardium, but you don't want to activate unnecessarily. STEMI alerts are very resource intensive. You can see that this electrocardiogram was done at midnight 45. Who wants to activate the STEMI team at 1 in the morning if it's not certainly a STEMI? This healthy 39-year-old man presented with chest pain for 2 hours, mildly unwell appearing. I didn't like the anterior leads. I bet you don't either, but I wasn't convinced. There was no old EKG. But here's the ECG 9 minutes later. No question now, is there? Repeating the ECG in 10 minutes is a very powerful, underutilized technique. Myocardial ischemia is a dynamic process. The ECG will be dynamic. But when the concern is STEMI, repeat the EKG in 10 minutes or 5 minutes, not 1 hour later. This one is also equivocal, done at 13:49. Unfortunately, the next one, which is much more obvious, is 14:52. The difference between repeating an ECG in 10 minutes versus 60 minutes is doing an awesome job versus a big miss. Hyperkalemia. Respect hyper-K. Here's another sort of cut-off attending note. There's a 52-year-old man, lots of medical problems, including kidney failure, presents with the complaint of high blood sugar and a request for a finger stick, capillary blood glucose. He spent an hour or two in the department, got this electrocardiogram, and then became, quote, belligerent, and then became bradycardic, and then unresponsive, and then arrested, and then was pronounced. This is electrocardiogram from 2 months ago. Old ECG on top, new EKG on the bottom. Hyper-K. It is such a killer. It is very common. It is very treatable. Keep it close to your heart. Next error is not to consider dangerous precipitants. It turns out that there are a series of problems that may not be obvious or may not explicitly prompt the emergency department visit, but often cause the symptoms that lead to the emergency department visit. And this set of precipitants is remarkably uniform across many conditions that prompt an ED visit. They are the precipitants of everything, which I've listed here. You can find them at emupdates.com/precipitants. Ask the question, why did this happen today? Be mindful of a dangerous precipitant, most famously in single vehicle accidents, but also hyperglycemia, withdrawal, arrhythmias. Ask the question, why did this happen today? Consider that there could be a dangerous precipitant. One thing that is almost never the precipitant is what the patient ate. Patients love to attribute their symptoms to what they ate. Physicians love to attribute patient symptoms to what they ate, but it's almost never what they ate. Remember that we eat 3, 4, 5 times a day. Before any symptom, including being hit by a bus, there was a meal. The meal seldom caused the symptom. The meal is almost always a red herring, or what I call a decoy diagnosis, which is a diagnosis that someone else suggests, like the patient or another doctor. 41-year-old man, sudden abdominal pain and diarrhea. New foods, pickles. Got labs, symptom control, felt better, discharged at 10:45 on August 24th. Returned 6 hours later looking bad. Obvious peritonitis. This is from the operative report, perforated appendicitis. Trending the white count from right to left. It's kind of interesting. When he was seen initially, he had a white count of 13.6. 10 hours later, when he came back with perforated appendicitis, his white count was 2.8. So in between those two times, his white count was normal. And then he got an operation, and he was in the hospital for a few days recovering. As you can see, the white count was normal post-op. in day one, and then on day two, look at that, another white count. I guess he got appendicitis again. Anyway, be very reluctant to attribute symptoms to a meal unless more than one person has the same thing and has the same symptoms. It's almost never the meal. Beware of the decoy diagnosis. That patient with ruptured appendicitis, when he was discharged at 11 a.m. because he felt better, because his appendix had just ruptured, what was his discharge diagnosis? Gastroenteritis, of course. The road to bad outcomes is paved with benign specific diagnoses, BS diagnoses. The most important are gastroenteritis instead of abdominal pain, migraine instead of headache, and, God help you, costochondritis instead of chest pain. I mean, at least gastroenteritis and migraine are actual conditions. I'm not sure costochondritis is even a thing. There's a good chance costochondritis is a disease made up by physicians who can't bear to tell their patients that they don't know what is causing their chest pain. Here's the letter I sent to the providers after this case was identified in clinical quality review. There are a number of reasons not to give your patient a BS diagnosis, but the most important reason is that when you tell the patient they have a benign condition, some of them will believe you, even if you're wrong, and they'll stay home if they get worse, which is exactly what you don't want. Fortunately, this guy did not believe us, and he came back to the same emergency department. I guess he didn't learn from his mistake. Do not convey certainty you don't have. Sir, we are not sure what's causing your pain. After our assessment, we see no evidence that there's anything dangerous going on, so we think whatever is causing your pain should get better by itself. But sometimes we're wrong, because sometimes people have a dangerous condition that just hasn't shown itself to us yet, that we can't see yet. So if you get worse, come back and see us. We're here 24 hours a day, 7 days a week. Here's my phone number. A BS diagnosis is a be sure diagnosis. There is no problem assigning a benign specific diagnosis if you're sure that's what the patient has. But if you're not sure, don't pretend you're sure. Don't let the patient think you're sure, because if you're wrong and they don't come back, that's very bad. And with chest pain and abdominal pain and headache and flu-like illness, we are almost never sure. So don't pretend you're sure. Don't assign a BS diagnosis. Those are just a few lessons learned from clinical quality review. There are so many more. And you will discover many more if you set up a robust, inclusive QI process in your department. Thanks very much for your attention.